Next up is Eric Sasemski. He's Director of Vascular Intervention at Beth Israel Deaconess Hospital in Boston, and he's going to be talking about medical management after CLTI ALI diagnosis. Thanks.
Great, thank you very much. And we've been talking a lot about ALI, and I got kind of a combined task here. So I'm going to focus really on the long-term management of medical therapy for peripheral artery disease as a whole, and in particular CLTI. I think we all know for ALI, most of these patients require full-dose anticoagulation for some period of time, and it really, again, going back to Liz's lecture, it really depends on that underlying reason, whether it's atrial fibrillation and a lifelong indication for anticoagulation versus something more limited or isolated. So we're going to step back and think about the bigger condition of CLTI, ALI, and PAD and where medical management's going. This is the talk Srini always gives me, and I always enjoy giving. So the first question I have, just painting the picture of what's happened over the last 2 decades is who cares about peripheral artery disease? Everybody here cares about peripheral artery disease, but what about the general community? And I go back to this really interesting study called the PARTNER study. And they went out to primary care clinics and they interviewed the physicians taking care of the patients and then the patients themselves in their chart review. And it was pretty remarkable that 83% of patients knew when they had a leg problem, including peripheral artery disease. Only half of the primary care doctors knew about the same condition. And this is very different when you compare that to coronary artery disease, when the majority of primary care physicians knew about their patient's coronary artery disease. So we've really had a tremendous problem of raising awareness, even just at the general community level. And you can see medical therapy suffers for patients here in dark blue with peripheral artery disease compared to those who have also or separately a diagnosis of coronary artery disease. And, I would say maybe we should care. Again, I give this talk frequently, and I just like to highlight, we all know the prevalence, but we also know that this prevalence is rising. And again, we're now well over 12.5 million patients in the US, 1 in 6 patients over the age of 60, and $21+ billion in annual healthcare costs. So you give this to your hospital center, you give this to your community, you give this to the government, what should we do differently, what's happened in innovation in medical therapy, and you'll be surprised on the size I'll show you in a minute because it's been minimal. Now, we've seen really nicely for ALI in particular, this comment for the cardiologist, at least in the crowd, that this is the STEMI of peripheral artery disease. And this is a figure just looking at mortality rates for an ST elevation MI. Those are the full occluded vessels in the coronary vasculature, 8% mortality 1 year, probably slightly older data, recurrent events of 3.5% at 1 year. And if you put that next to ALI, and this is courtesy of Mark Banacca, who's led a lot of the anticoagulant therapy for this, you can see mortality rates are higher for ALI, recurrent risks are higher for ALI, amputation rates are more severe than an average diagnosis of heart failure. But we spend such little time talking about ALI, and we spend a lot of time talking about ST elevation MI. So this is the disappointing slide of this talk. This is medical treatment for peripheral artery disease over the last decade and a half. And we've spent more time in our guidelines taking away agents than adding agents. And I'll just walk you through here. You can see that we've been downgrading different types of medical therapies, including fibrates, which is a cholesterol medication. We took pentoxifylline off altogether, you'll see later on, or class 3. And then also we got vorapaxar, which is a direct thrombin receptor inhibitor that has such high bleeding risks versus their efficacy that it's not really used at all in clinical practice. So I give you a first start of this that's saying that 12.5 million patients are diagnosed with peripheral artery disease, $20+ billion in costs, and we can't find medical therapies that help, at least in the post or pre-side of this disorder, reduce events. So, right now, based on our current guidelines, the indication for medical therapy is antiplatelet with aspirin and or clopidogrel, a high-potency statin, and ACE or an ARB for hypertension and smoking cessation. That's what we got right now. So I'm going to try to show you some difference. Now, this is another great slide by Mark Banacca, and these are all our attempts over the last 3 decades to change that. And some of these are what got clopidogrel on. We saw this in the CAPRI trial, but later on we've been looking through studies of anticoagulation and dual antiplatelet therapy. I'm going to highlight in a moment, and then really where therapy is going to go from here. So dual antiplatelet therapy, again, as an interventional cardiologist, this is what we love. We use this every day. We have trouble letting go of dual antiplatelet therapy. We spend more time now trying to get people on lower durations of dual antiplatelet therapy. 10 years ago, we spent a lot of time trying to get people on longer durations dual antiplatelet therapy. But for the periphery, we really struggled to find a great value of dual antiplatelet therapy. So we were talking about this yesterday, and one of the biggest trials was CASPER. So CASPER was a below-the-knee bypass grafting trial for peripheral artery disease, and they looked at aspirin alone versus clopidogrel plus aspirin. And you can see at the bottom slide here that although there was potentially some small signals of benefit, really this was just more bleeding and more mortality. And so really this just fell off the whole discussion about what's the right role for dual antiplatelet therapy, at least in the below-the-knee grafting space. We don't have a ton of trial in the peripheral endovascular space. The MIRROR trial was the hope that this would provide us with one randomized trial. It was really an underpowered study that really didn't show significant benefit of dual antiplatelet therapy after an endovascular approach. And we've seen this also in real-world studies. This is a study of CLI patients that were published recently looking at amputation-free survival, and really no significant benefit if you keep dual antiplatelet therapy on over the long term versus aspirin alone. Now, if you look in registry data, though, most people are keeping their patients on dual antiplatelet therapy from far longer than the IFU indicates for an average endovascular device. So typically 1 to 3 months is all that's indicated. You'll see in registry studies at 6, 12 months of dual antiplatelet therapy is being used frequently without any data, probably more higher bleeding, and really it's something that needs to change. So we're going to talk for the next part of this just about anticoagulation here. And so this is a typical med school figure of what happens when a thrombus forms in the setting of underlying arterial disease. And we know that this is a mixed process that includes both fibrin, thrombinogen, we know all the different thrombus components, but also platelets. And we spent so much time talking about platelets that we don't talk about the other components. And in chronic limb ischemia or chronic limb-threatening ischemia, we know that thrombotic occlusions are very likely part of the process for moving it from a stable or chronic PAD patient to an unstable or CLTI patient. We saw this in a really nice paper that came out in JACC just a few years ago, looking at autopsy data of amputated legs, histopathologically data showing that very normal vessels in the below-the-knee space with intraluminal thrombosis, suggesting that there's either in situ thrombosis, arterial thromboembolic processes going on, and really laid the groundwork for why anticoagulation is going to be an important part of our long-term plan for our CLTI and ALI patients. And again, when you're thinking about this lovely med school figure, we know that the interplay between the coagulation cascade and the platelet activation are tied together. So agents like factor Xa inhibitors do a nice job of not only reducing the coagulation cascade, reducing thrombin generation, but also keeping platelets from being activated. So we spend so much time with our P2Y12 inhibitors on the right, not enough time on the left side. So why not warfarin? Well, this is really the only trial, there's a few, but really the only trial that looked at warfarin in the setting of infrainguinal bypass grafting. And in the BOA trial, one problem with this trial was a high goal for INR, 3 to 4.5. So quite a remarkable goal to reach on warfarin alone. But you can see here that really warfarin had no significant benefits in terms of graft occlusion and a significant amount of stroke and intracranial bleeding. So we really stopped even thinking about warfarin. And that, however, gave us the opportunity to think about other agents have a better safety profile. So everybody should be familiar with the next few slides, because this is where our field is going. COMPASS PAD was a subset of a larger trial looking at low-dose Xarelto, 2.5 milligrams twice a day. And in this, you had to have either symptomatic coronary disease or peripheral artery disease. In the subset of this group that was published in Lancet, this is only patients with symptomatic lower extremity peripheral artery disease or carotid artery disease. And if you're on a protocol of 2.5 milligrams of Xarelto twice a day plus aspirin, not only did you have lower systemic cardiovascular events, you had lower major adverse limb events, it's shown here on the right, and lower risk of amputation, with a very small signal of increased bleeding, but none of which was life-threatening or intracranial hemorrhage. When you move to the more recent VOYAGER PAD trial, this is a study looking at Xarelto 2.5 milligrams twice a day plus aspirin, 81 milligrams to 100 milligrams, versus aspirin alone. You can use clopidogrel in either arm at the discretion of the operator. And you can see this is both surgical and endovascular treatment, that the primary outcome is reduced with the protocol of Xarelto. And you can see these curves start to separate pretty early on, right around 90 days. So that benefit's achieved very early into the treatment protocol with really no increased risk of severe bleeding events. And when you look at some of the sub-analyses up here, it's really nice to see acute limb ischemia as a primary or sub-endpoint of the composite endpoint, because this is really relevant to patients undergoing a treatment such as surgical endovascular revascularization. And you can see that Xarelto really showed a signal of consistency for being the better agent versus placebo, irrespective of clopidogrel use. The other really important part of this was a claudication and CLI population. And so when you break this down by patients who either had CLI or not, we still saw that really nice reduction in long-term events. Now, again, mortality rates are much higher in the CLI population, but if you're able to keep patients on this for several months to years, you're going to achieve a benefit with Xarelto 2.5 milligrams twice a day plus aspirin versus being just on a single antiplatelet agent. So I will leave this with the comment that our medical therapy will change. I think this will 100% change our practices that haven't already. Rivaroxaban 2.5 milligrams twice a day really is becoming the standard of care with aspirin for how we take care of our patients. We're not talking about full dose warfarin. We're not talking about dual antiplatelet therapy anymore. And I think everybody knows the importance of these other agents in smoking cessation for all our PAD patients. Thank you very much.